Good afternoon, my dear friends. Our topic for presentation today is congenital diaphragmatic hernia. What is congenital diaphragmatic hernia? Congenital diaphragmatic hernia is the herniation of abdominal contents towards the thorax through an opening in the diaphragm. It is called congenital diaphragmatic hernia. When we hear first about the congenital diaphragmatic hernia, we only see the hole in the diaphragm through which the contents of the abdomen herniates to the thorax. But it is much more than that. There are a conglomeration of events happening in congenital diaphragmatic hernia, resulting in developmental anomalies in various systems, various organ systems. Let us discuss and how these children goes into mortality, how these children can go into high levels of mortality, and how these children can be retrieved. Let us discuss this topic. Now, we will discuss this topic under the headings embryology, pathology, clinical presentation and diagnosis. Then we will go in for the prognostic factors of congenital diaphragmatic hernia. When not to do surgery. Is doing surgeries in the patient is worth taking the effort. Sometimes even after all our procedures, the child can die. Is there any point in doing surgery in cases like that? The prenatal care in case of congenital diaphragmatic hernia, and before the surgery per se, or before shedding the blood, the resuscitation and medical care in congenital diaphragmatic hernia, then the when and how of surgery, when to do surgery and how to do surgery, the timing of surgery. Now, finally, we'll come to the outcome of surgery. Do all these patients live happily ever after their surgery? The modern and the future of congenital diaphragmatic hernia. And finally, a word about Morgaginian hernia and eventuation of diaphragm. Now, coming to the developmental part, how the different parts of diaphragm are developed. We can see that the anterior part of the diaphragm is developed from the sphincter. The anterior part of the diaphragm is developed from the septum transversum, the central tendon and the anterior part. Then another part of the posterior parts of the diaphragm are developed from the pleuroperitoneal membrane on both these sides. Then the crux of the diaphragm is developed from the esophageal mesentery, and the lateralmost portions of the diaphragm are developed from the outgrowth of the body wall. These are the different parts, different parts from which the diaphragm is developed. But when we hear these words, we don't know what all these stands for, the septum transversum, the pleuroperitoneal membrane, etc. The problem with the embryological development is that when we see all these layers, when we see all these structures like septum transversum, pleuroperitoneal membrane, etc., we do not know where they are coming from. So in order to just understand that, we just suddenly brush through the embryology of go through the embryology. These are the three layers we see: the ectoderm, mesoderm, and the endoderm. Where the endoderm gives rise to endodermal sinus structures, we can see the neural tube forming, and we can see the division between somatic mesoderm and the splangling mesoderm and the intraembryonic coelom. We have to see the intraembryonic coelom. It is now later going to a development of the thoracic cavity and the abdominal cavity. You can see the passage of fluid into the intraembryonic coelom. It divides into the primary pericardial cavity near the heart and the peritoneal cavity below it. This is the movement of the fluid in the intraembryonic coelom. This is the cut section of the intraembryonic coelom. This part near the heart develops into the pericardial cavity, and this part into the peritoneal cavity, and this is the pericardioperitoneal canal, the pleuroperitoneal canal, where this membrane which is developing across this is the pleuroperitoneal membrane, and this part and the part near the heart develops into the septum transversum. So this is the transverse view or the development of the body cavity, and here we see the development of the thorax here. This is the embryonic gut tube and the dorsal mesentery. You can see this is the pericardioperitoneal canal. Then now let's see the formation of the diaphragm and the development of thorax. You can see around the 5th week, we can see the cut section of the embryo. That is during the development of the diaphragm. This is the septum transversum. This is the pleuroperitoneal membrane and the esophageal mesentery. And we can see the pleuroperitoneal membrane develops and the septum transversum grows backwards, and finally there is the outgrowth of the body wall. This is the different structures in the development of diaphragm. The diaphragm also descends downwards through the development. Descends as the development progress. The diaphragm descends downwards. What is happening during this period in the thorax? Let us see. This is the cross section. We can see that the pericardial cavity here, and the pericardial cavity develops, and the lung buds are formed, and the pleural cavity is also formed. We can once more see the cavity here, the pleuropericardial cavity. It changes in shape and it covers around the lung. In abdomen also we can see the contents are coming out, abdominal contents are coming out, then going in, and the rotation of the bowel happens in the complex rotations of the bowel happens during the period in the counterclockwise direction, and the descent of the cecum. All this happens during the period of development of the diaphragm. So once all these bowels are going into the thorax, there can be some amount of partial malrotation in the bowel. So the bowel related symptoms in congenital diaphragmatic hernia can be either due to malrotations or can be due to adhesive coli. The malrotations are not immediately addressed during the period of congenital diaphragmatic hernia. First, the congenital diaphragmatic hernia is repaired, and then only once the patient is stabilized, only the malrotations will be addressed later. Now, in brief, we know what is happening in the lung and abdomen. But how does the congenital diaphragmatic hernia affects the lung development? For that, we have to know in short about the lung development. The lung goes through different developmental phases: the embryonic, the pseudoglandular, canalicular, saccular, and alveolar phase. The in vitro phase is until the alveolar phase, until the canalicular phase, and the saccular and alveolar phase happens in the 27 to 36 weeks and even after birth. In the early development, the tracheobronchial development happens in the embryonic, pseudoglandular, and canalicular phase, whereas in the saccular and the alveolar phases, the development of the alveoli or the terminal bronchioles happens. In the next phase, we can see the pulmonary artery development. The major pulmonary vessels are developed in the earlier phase up to the 26 weeks along in conjunction with the embryonic, pseudoglandular, and canalicular phase of the major airways, whereas this part, the last part from 27 weeks up to 2 years, even up to 2 years, the last 27 to 36 weeks, the development of the minor pulmonary vasculature, the smaller pulmonary vessels, develops along with the development of the alveoli. That is a major factor in determining whether there is pulmonary hypertension developing in the patient or not. If the alveolar development is not proper, the pulmonary vasculature development will not be proper. That will result in decreased pulmonary vasculature development in the distal alveoli and the distal terminal bronchiole, which results in pulmonary hypertension. And pulmonary hypertension can act as a core component in determining the mortality or the survival of congenital diaphragmatic hernia. Coming to the development of the heart. How does congenital diaphragmatic hernia affects the hearts? In the lung, it affects by the decrease in the development of the alveoli and causing the pulmonary hypertension. In heart, what happens is, for that, what happens in normal fetal circulation? We will see that. In normal fetal circulation, the blood from the right heart drains. It can drain into the, can go like that. It can go to the atrial septal defect, right atrium, go to the atrial septal defect, through to the left atrium, then to the left ventricle, and then to the aorta. It can also go in another method. The blood from the right atrium can go to the left atrium, then it goes to the blood from the right atrium can go to the right ventricle, and then it goes to through the pulmonary artery. You can see when it reaches the pulmonary artery, it can either go to the lung or it can go through the patent ductus arteriosus into the aorta. In fetal circulation, the majority of the blood goes from the pulmonary artery into through the peritonic arteriosus into the aorta. Why? Because the lung is not developed. There is high amount of pulmonary hypertension in the lung. So the blood cannot go to the lung, or the minimal amount of blood goes to the lung. But what happens once the birth occurs, the child respires, the alveoli expands, the pulmonary vascular pressure decreases, and the lungs will become, the pulmonary vasculature becomes a low pressure system, and instead of the blood going to the aorta through PDA, it goes into the lungs after birth. But in case of congenital diaphragmatic hernia, the pulmonary vasculature is not developed well. There will be increased pulmonary hypertension, resulting in persistent pulmonary hypertension, which can prevent the patent arteriosus from closing and atrial septal defect, and prevents atrial septal, and also prevents the atrial septal defect from closing. So persistence of fetal circulation is another feature of congenital diaphragmatic hernia. Coming to the antenatal diagnosis in congenital diaphragmatic hernia, the mean gestational age of discovery is around 24 weeks. The features with the mother shows are polyhydramnios. In the child, in ultrasound of the child, we can see the shadow of the stomach in the fetal thorax. The fetal lung volume will be decreased, and the lung to head ratio between the, if the lung is not developing like the head of the patient, if the head of the patient is developing and the lung is not developing, we have to suspect something which prevents the development of the lung, and which can be congenital diaphragmatic hernia. This is the ultrasound picture of the fetus showing stomach in the thorax. Now coming to the postnatal diagnosis. Once the child is born, we have to look for signs. How will we clinically evaluate the child and find whether there is congenital diaphragmatic hernia for this patient? We have to look for the signs of respiratory distress, cyanosis, and indrawing of the intercostal muscles or the respiratory muscles. And there are features of increased effort of breathing. The patient, since all the contents of the abdomen, or most of the contents of the abdomen, jejunum, liver, and even spleen can go into the thorax. So there is a scaphoid abdomen. The abdomen will be flat, and as all the abdominal contents are in the thorax, the trachea, you can see the enterotracheal tube here, the trachea will be shifted to the opposite side. You can also see, due to the presence of bowel in the thorax, that side of the chest will be distended and there will be decreased movements. In these cases, in the early period, echocardiography and both cranial and renal ultrasounds are helpful in evaluating the survival, evaluating the prognosis of the patient with congenital diaphragmatic hernia. When more systems are affected, or there is a multiple congenital anomalies, the chances of survival are less. Coming to the prognostic factors. What are the prognostic factors? We can divide the prognostic factors into anatomical factors, physiological factors, physiological parameters based on ABG analysis, and ventilator parameters, and finally pulmonary function tests. The anatomical factors, when these anatomical factors are present, it is a bad prognosis. Anatomical position of the liver, if liver is in the thorax, it is a bad prognosis. The position of the stomach in the thorax, again a bad prognosis. The right-sided defects are associated with worse prognosis compared to the left. Even though the left-sided congenital diaphragmatic hernia is more common than the right side, right-sided defects are associated with worse prognosis. Lung to head ratio. In lung to head ratio, the contralateral lung area divided by fetal head circumference is looked. When the contralateral lung is also compressed by the contents of the bowel on one side, suppose the bowel is herniated onto the left side and it is compressing the contralateral lung, the development of the contralateral lung will also be reduced. So if the contralateral lung area is decreased, the chance of pulmonary hypoplasia is more, and the patient going for a respiratory failure is high. So lung to head ratio also is an important prognostic factor. Then Magoon index and pulmonary artery index. Both these indices are measures of increased pulmonary hypertension. When pulmonary hypertension is more, the prognosis is poor because there can be the increased chance of respiratory failure in features with increased pulmonary hypertension. Physiological parameters are based on ABG analysis, and ventilator parameters include modified ventilator index and oxygenation index. Pulmonary function tests can be useful, especially in older age group. In younger and newborn children, it is less useful. Prenatal diagnosis. If prenatally congenital diaphragmatic hernia is detected in utero, it is a bad prognosis. Low birth weight, Apgar scores, and right side defects all are associated with low Apgar scores all are associated with bad prognosis, and they are individual bad prognostic factors. Now, just a word about the physiological parameters. When the patient is put onto ventilator, these physiological parameters measure whether the child is improving in ventilator. If the child is improving with adequate oxygenation, it means that the degree of pulmonary hypoplasia is less. If the pulmonary hypoplasia is less, or if the lung development is good, then the chances of survival are more. Now, coming to the treatment of congenital diaphragmatic hernia, we can divide the treatment into prenatal care, preoperative care, and surgical management. Coming to prenatal care. Prenatal care, main thing is we have to search for other congenital anomalies. If it is a part of the syndrome, the chances of survival are less. We have to look for skeletal defects. We have to look for cardiac anomalies like ventricular septal defect, tetralogy of Fallot, transposition of great arteries, DORV, and coarctation of aorta. Then tracheobronchial tree anomalies and neural tube defects. We have to prepare the parents about the chances of congenital diaphragmatic hernia, and there is a chance of pulmonary hypoplasia, and there is chance of decreased survival, and the requirement may be, and there may be a requirement of surgery for the patient in the post-operative period. And spontaneous vaginal delivery is preferred in congenital diaphragmatic hernia if there are no other obstetric indications. So in congenital diaphragmatic hernia, spontaneous vaginal delivery is preferred. Now, coming to preoperative care. Now, resuscitation is a very important part as far as congenital diaphragmatic hernia is concerned. It is to reverse the pulmonary vascular resistance. How does resuscitation reverse the pulmonary vascular resistance? In resuscitation, we have to put an endotracheal tube. We have to intubate the patient. An nasogastric tube has to be put to decompress the abdominal content, so that the abdominal compartment pressure is decreased and the air in the bowel is escape out, and the bowel comes down into the abdomen. Ambu bag is contraindicated because we can push in air both to the abdomen and to the lung. So when the bowel is filled with air, there is more chance for an increased herniation of contents to the thorax, which causes increased pulmonary problems. Adequate IV access, umbilical line is preferred. No need for a chest tube in case of congenital diaphragmatic hernia, and the patient will have metabolic anomalies like metabolic acidosis, so which also has to be corrected. In case when the patient is resuscitated and adequate oxygenation is given, pulmonary vascular resistance is reversed. How? When there is hypoxia, there is pulmonary vascular contracture and there is increased pulmonary artery hypertension. Pulmonary hypoxia, pulmonary vasoconstriction, increased pulmonary artery hypertension, which acts as a vicious cycle just like that. So we break this by giving adequate oxygenation, so which results in better oxygenation and decreased pulmonary vascular contraction and reversal of the pulmonary vascular resistance. Now, ventilate the patient. Avoid paralyzing the patient, because we have to see how the child is responding, whether the child is going to survive, whether the child has got enough length to survive, whether is the pulmonary hypoplasia so bad. We have to understand that. So, paralyzing the patient does not help. Avoid paralyzing the patient. Ventilator settings we can do two types of ventilator setting. We can either set a range of low rates and moderate peak airway pressure to high frequency oscillatory ventilator. if we the better initially the low rates and modest airway peak pressure are better. We give a low rate and give an adequate airway pressure so that the alveoli can expand. But even with that, when that even if in those rates and in those pressures, if the oxygenation is not maintained and we have to increase the pressure to increase the oxygenation, there is a high chance for barotrauma. So in those conditions, high frequency oscillatory ventilation is preferred, where where small amounts of tidal volume are given in a high frequency rate in order to maintain the minute volume and oxygenation. Now, pharmacology, this is what happens. The preoperative care generally happens in the neonatal ICU. Even though many drugs like surfactants and nitric oxide drugs are said, they are of no much help. Surfactants, there is no overall benefit, and nitric oxide also there are no proven benefits. Basically, how the development of the child and the surgery per se helps the patient to survive. Suppose the child is not surviving, the child is not improving by even just by ventilation. That is, there is no adequate length, or the length for the time being is not adequately functioned, or there is some degree of pulmonary hypoplasia or some degree of increased pulmonary vascular resistance. What we have to do is, oxygenation of the blood has to be done outside by the membrane oxygenator, that is extracorporeal membrane oxygenation. This is the concept of extracorporeal membrane oxygenation, where we take the blood from the venous system of the patient and take it into a membrane oxygenator, and through a pump take into a membrane oxygenator, oxygenate and return the blood to the venous system. It can be done in two ways. It can be a venous ventilator, where we take from the vein and return it to the oxygenate and return it to the vein, or we take from the artery and then return it to the vein, arteriovenous membrane oxygenation. It can be done in two ways. If you put the child in extracorporeal membrane oxygenation, will the child survive? The child can survive if the prognostic factors are better, but the child may not initially die because the oxygenation is happening, and the child will just survive with a bad prognosis. If there are multiple bad prognostic factors, it only increases the cost of healthcare, nothing else. So the decision of whether to put on extracorporeal membrane oxygenation, ECMO, extracorporeal membrane oxygenation, ECMO, is very important. So the decision can be taken upon by degree of reversible pulmonary hypertension, whether the pulmonary hypoplasia is present, and depending upon the oxygenation index and alveolar arterial oxygen difference. Even though all these parameters can help us, it is finally a clinical decision. It appears like a complex circuit. But what exactly happens is, we remember how does it act? We remember our fish tank. In fish tank there is a pump. In that pump, what happens is, it takes the water, oxygenate inside that filter, oxygenate and cleans inside the filter, and put back into the fish tank. That is what happens in our fish tank pump. Same thing happens in the extracorporeal membrane oxygenation. The water is taken and it is oxygenated inside the blood is taken, it is oxygenated inside the membrane oxygenator and is given back to the body of the patient. Coming to the timing of the surgical repair. When to do surgery for this patient? Should we do immediately as soon as the child is born? Congenital diaphragmatic hernia is a physiological emergency and not a surgical emergency. There is no emergency in doing the surgery per se. It is a physiological emergency. Why? Because the patient period of medical stabilization and delayed surgical repair is found to have better results than the early surgical intervention. So, how long to wait? How long will we wait for these patients to get stabilized? Some patients will not stabilize at all. So, waiting until the infant is successfully weaning off from the mechanical ventilation. The child is showing features that he can be weaned off the mechanical ventilator, or requiring low ventilator settings of low FiO2 and low pressure settings, where the child is showing features of getting weaned off from the mechanical ventilator. That means the child has adequate length to sustain life, and so those patients are candidates of surgical repair, and we can wait until that. Generally, or around 48, generally roughly it will be around 48 hours. By around 48 hours, the decision can be made. Or another is wait until the pulmonary hypertension can be abated or at least stabilized. This we can identify using the echocardiography, looking for the pulmonary artery caliber and the thickness and pulmonary area of the cut section of the pulmonary artery. Now coming to the surgical repair, what are the surgical options? Generally, general anesthesia is given for these patients. The patient is positioned supine, elevating the thoracolumbar spine. The chest and upper abdomen are prepared. The incision is made 1 to 2 cm below the costal margin. The stomach is decompressed and the defect is exposed. The stomach, by nasogastric tube aspiration, the stomach is decompressed and the defect is exposed. Once we see the defect, the basic thing is we should not pull the bowel first. We should introduce air into the defect and allow the bowel, and after that, so that the negative suction pressure inside the thorax decreases, and then the bowel is slowly reduced to the abdominal cavity. Then once the bowel is reduced into the abdomen, we can clearly see the defect with its margin. It will generally have an anterior and a posterior margin. So we should take sutures from the anterior and the posterior lip. The posterior lip can be sometimes rolled down, so we have to specifically look for the posterior lip. Sometimes it will not be easily visualizable like this. Then we have to take sutures from both the edges of the defect with non-absorbable sutures. If a true hernia sac exists, it must be excised, and this is the appearance of the sutured defect. We can also see in this picture that the spleen is one of the last organs to reduce in congenital diaphragmatic hernia, and interrupted simple non-absorbable sutures are generally used for the repair. Sometimes you see that you cannot bring the edges of the edges of the defect together. The defect is so large. Then what we have to do is we have to keep a mesh and repair the hernia. Sometimes there may not be enough posterior lip, only rib will be there. So in that case, we have to take sutures like this from the mesh towards the rib. That is regarding the technique of the thoracoscopic approach can be also done when the defect cannot be closed by primarily. A PTFE patch can be cut to size. This is the surgeon. These are the position of the surgeon, assistant, and monitor, and anesthesia in case of congenital diaphragmatic hernia. In thoracoscopic repair, we can also see the port positions, and with the help of a peanut Kittner forceps, the defect can be visualized, and the edges of the defect can be sutures. Essentially, the steps are similar. It is basically the suturing of the defect with the between the anterior and posterior leaf of the defect, but the approach is different in the thoracoscopic approach. Outcome: does all these patients with congenital diaphragmatic hernia live happily? No. Many a times they have chronic obstructive pulmonary disease. If there are cardiac anomalies, the prognosis is generally bad. These patients are affected with developmental delay because the position of the stomach has been in the thorax. The development of the gastroesophageal junction will not be normal, and that can be a gastroesophageal reflux disease. The patient has hearing defects. Some scientists attribute it to the aminoglycosides which is given in the perioperative period, and some cases there can be recurrence, and in many of the cases there can be adhesive intestinal obstruction in case of congenital diaphragmatic hernia. When we say future, whether there are any utility for in utero intervention of congenital diaphragmatic hernia. In this case, one method which is not exactly a future, it is already been practiced, is in utero the trachea of the fetus is plugged. So what happens is, when the trachea of the fetus is plugged, there is increased buildup of pressure in the thorax, and which helps to the you see the balloon is inflated and the balloon is detached here, maybe to the, which helps in the increased volume of the lung. Due to the increased pressure in the lung, there can be increased volume and increased development of the lung. Yes, that is true, and that has happened like that. But the thing is that only the quantity of the lung is increased. The quality of the lung is poor, and these patients are also going to respiratory failure. And it is found that it is of no much use, and in many cases, this procedure is now virtually abandoned. Another method is liquid ventilation. In this case, suppose the air is given, there is high pressure, it has to be given in high pressure, there is a chance that there is a high amount of barotrauma. So it is a liquid which is oxygenated, and it acts like air. Actually, in case of liquid ventilation, we breathe like a fish. The fish takes the water inside through the gills, and it gives the water. It sends the water outside. Like that, we breathe the water. The PTFE is in liquid form. We breathe PTFE in liquid form. We breathe it through the endotracheal tube, and lungs are oxygenated. Because due to the liquid consistency, it helps in the increased development of the alveoli due to the pressure effect. And after that, after adequate oxygenation, the brought out. That is the liquid ventilation. The fetal intervention is by tracheal occlusion, and intraalveolar fetal albumin administration canals is shown to help a bit in the development of the lung, and liquid ventilation with perfluorocarbons, and which can help in pulmonary distension. Now, a word about Morgagni hernia. It is more common on the anteromedial and the right side, when the congenital diaphragmatic hernia is generally more common on the left side and posterolateral side. Bogdalek hernia. Bogdalek hernia is patent pleuroperitoneal canal. It is more common on the left side and towards the posterolateral aspect. I remember like Bogdalek. It is in the back and the lateral So Bogdalek. Whereas in the Morgagnian hernia is on the anteromedial side. It develops in the embryological space of Larry. Embryological space of Larry is the space between the development when the body growth of the body wall in the development of the diaphragm is impaired. It can result in especially in the anterior part. It results in the Morgagnian hernia. It presents more commonly in older children and in adults. Hernia is often discovered incidentally as a mass or air fluid level in the chest radiograph. In that case, the diaphragm is sutured to the underside of the posterior rectus sheath at the costal margin. A word about the eventration of diaphragm. Eventration of diaphragm can be congenital or acquired. When the eventration of diaphragm is congenital, it is indistinguishable from diaphragmatic hernia with sac, or when it is acquired, it is associated with birth trauma like Erb's palsy or phrenic nerve. In eventration of diaphragm is like a nerve injury which results in the atrophy of the diaphragm. Even though all the layers of the diaphragm are present, it will be very thin. The muscle will be very thin, so that it will appear the diaphragm jets out in the thorax because it has no tone at all. It has no muscle at all. So it will appear like a diaphragmatic hernia. But actually the diaphragm is not torn. There will be a membrane over it. The diaphragmatic muscle is usually present in its normal distribution, but it is attenuated and inactive in acquired. A lateral chest radiograph is essential for the evaluation of eventration, especially on the right side. Fluoroscopy of the chest with ultrasound examination, the diaphragm moves paradoxically. When there is a negative intrathoracic pressure in inspiration, the diaphragm moves upwards in case of eventration of diaphragm. Normally, when there is in respiration, the diaphragm moves downwards. In case of eventration of diaphragm where it is not functioning due to the negative intrathoracic pressure, the flaccid diaphragm moves upwards, moves paradoxically. The small eventration may be left untreated. Repair is indicated when there is a large functional deficit. Relaxing incision during repair is helpful to prevent recurrence. In brief, we have discussed about the development of the diaphragm, the development of pleuroperitoneal canal, the central tendon, the pleuroperitoneal, the outgrowth of body wall, where there is Morgantian hernia, where we have discussed about the Morgantian hernia, the embryological space of Larry, and the Bogdalic hernia due to the defect here, the posterolateral side and on the left side. Then we have discussed about what is happening during the period development of diaphragm in the thorax and in the abdomen, and the problems is with those, and in the what is happening in the lung and the development of lung in detail, and the cause of pulmonary hypertension in those patients, and the development of heart and the persistence of embryonal circulation in case of congenital diaphragmatic hernia, and the antenatal care in case of congenital diaphragmatic hernia. The postnatal diagnosis, where we see the classical X-ray, which showing the mediastinal shift, the bowel loops, and the endotracheal tube showing the trachea, this shift of the trachea to the opposite side, and resuscitative phase and ventilation of the child in the early period, and the surgical technique per se, and different type of surgical approaches like thoracoscopic and open approach. Then the future of the diaphragmatic hernia, and the eventuation of diaphragm and Morgantian hernia. With this, let me conclude my words, my friends. Thank you.